Now it's my pleasure to introduce Dr. Heng, who's already been referred to a few times here. He is a staff medical oncologist here at the Tom Baker Cancer Center. He's a clinical assistant professor of medicine at the University of Calgary. He received his MD from the University of Calgary, completed his internal medicine and medical oncology residencies at the University of British Columbia in Vancouver. He was trained at the BC Cancer Agency and then completed an experimental therapeutics fellowship at the Cleveland Clinic Taussig Cancer Institute. He also has a Master's of Public Health from Harvard University. Here in Calgary, he's the chair of the genitourinary, so that's kidney, bladder, testis, prostate, tumor research group in Calgary, and he's the chair of the International Metastatic Kidney Cancer Consortium. And this database is now actually led to many publications, and it's very great for all of us Canadians to go to medical conferences and hear them refer to the Heng criteria now. He has a keen interest in outcomes, prognostic factors, and clinical trials research in metastatic kidney cancer. And it's my pleasure to welcome Dr. Heng.
Thanks so much, Joan. You sure know how to make me blush. Thank you very much for all of you coming here today. You're sacrificing your family dinners. You're sacrificing the ability to watch Criminal Minds on Channel 7. Thank you very much for coming. I appreciate it. It's a great place to meet other people with kidney cancer as well. And it's actually really heartwarming to know that I know more than half of you in here. So let's go through this. I'm here to talk about stage 4 disease. So Dr. Kawakami, one of the best surgeons here in Calgary, actually, he talked about stage 1, 2, 3 disease, a little bit about stage 4 disease where you take out the kidney sometimes. But I'm here to talk solely about stage 4 disease, which is metastatic kidney cancer, where the kidney cancer has already spread somewhere else. So before we begin, I just want to add in a few caveats. This is an information session only. It does not replace your medical advice that only your urologist or oncologist can give you. We will be distributing these slides on the internet. What I'll talk about is a bit of a background, so before and after our current treatments. I'll talk about VEGF and mTOR inhibitors, which are most common drugs that we use today. And always, what everyone's interested in is what's happening in the future, future research, and what's new. So Dr. Kawakami already went through this. Staging, stage 1, inside the kidney, less than 7 centimeters. Stage 2, greater than 7 centimeters. Stage 3, there might be one lymph node out there, or it might involve a vein, a major vein, or the adrenal gland. And then there's stage 4, and it's stage 4 that I'd like to talk about. But just to go back a step in terms of what is kidney cancer, I think all of you know this already, but cancer is something like an errant cell. So inside the body, there are billions of cells in the body, and their growth and proliferation is very carefully regulated. There are checkpoints. There are checkpoints that say, no, you should stop growing now, or checkpoints that say, well, maybe you should reproduce because we need a bigger toenail, or something like that. So all of those checkpoints are very important in the cell cycle. And in cancer, the checkpoint is dysregulated. Something's wrong with it. The brakes are not on the cell, and the cell actively proliferates. It actively grows, despite the fact that it shouldn't be. So kidney cancer is one of those cancers. It's in the kidney. And before, I must say that if you were to talk to us about 7 years ago, 5 years ago, we really wouldn't have much to offer you other than surgery. We would give interferon or IL-2 in the olden days, and those were horrible drugs. IL-2 you have to go to the ICU for. You have to be on drugs to increase your blood pressure because your body is barely able to keep up your blood pressure because of the side effects of those drugs. And unfortunately, despite all those side effects, they weren't very effective. The response rates, the tumor shrinkage rates, were no more than 15%. So we only reserved those drugs for the young, really fit and healthy, and people who really wanted treatment, despite knowing that the response rate was really poor. So clearly at that time, 7 years ago, new therapies, better treatments were desperately needed. So we had interferon. It only worked a little bit of the time. There are lots of bad side effects. So we really needed something new. And this is what's new. And this many of you already know about. But it's only been in about the past 5 or 6 years that we have targeted therapy. So targeted therapy is not quite the same as chemotherapy. It's more sorry, there's a code 66 going on. Targeted therapy isn't quite the same as chemotherapy. The side effect profile is a little bit less. And targeted therapies try to target that molecule that's errant. So try to really hit that molecule very specifically to try to prevent things from growing. So the buzzword in kidney cancer treatment is angiogenesis. So the derivation of that word is new blood vessel formation. That's what it means. So as you can imagine, as kidney cancers grow, they need new blood vessels to form in order to feed it nutrients, in order to feed it minerals and oxygen. And normally, normal cells have this regulated very well. But in kidney cancers, it's really upregulated. So there's lots of blood vessels forming. So if you ask Dr. Kawakami, what does a kidney cancer look like when you take it out? It's really vascular. There's lots of blood vessels in it. It's very bloody. And that's just the way kidney cancer grows. One of the things that promotes angiogenesis is something called VEGF, Vascular Endothelial Growth Factor. And what it is it's something that's secreted by the tumor cell, and it's a signal. It's a signal that goes towards blood vessels to tell them to grow. It's a signal to tell blood vessels, you know what, I need more oxygen, I need more nutrients, I want to be greedy right now. And so it's going to make all of these blood vessels grow to feed this tumor to allow it to grow more. And so why is this important in renal cell carcinoma and not so much in other cancers? Well, it's because RCC is very, very vascular. Some of the other cancers that we hear about, like breast cancers, like brain cancers, for example, they're not as vascular. And so that's why these drugs work much better in renal cell carcinoma. There's actually something, how we discovered this was a bunch of kindreds of people, a bunch of families had a lot of renal cell carcinoma. It was hereditary for some reason. And we really weren't sure what happened. And this happened long, long ago. They actually found a gene defect in those patients, something called von Hippel-Lindau syndrome. People with kidney cancer, not everyone has von Hippel-Lindau syndrome. In fact, it's actually really rare. But by discovering that gene syndrome, that's actually how we discovered that VEGF, that angiogenesis was really important in kidney cancer. So let's talk about one of the most common drugs for kidney cancer, Sunitinib. Many of you may have had experience with Sunitinib, but it's our first-line drug that we use, or one of the first drugs that we use for metastatic renal cell carcinoma. The response rate for Sunitinib is good. About 40% of patients get a big tumor shrinkage. Another 40% of patients have disease stabilization. And the other 20% of patients, it doesn't work as well. But this is just an example of a CT scan. And if the stars align, I can use a pointer. Over here, you can see this is a CT scan. And what a CT scan is, it cuts your body like this. And you're essentially looking at the body from down here. And over here, that's the back. This person is laying down. This is someone's front. This is actually around the area of the heart. And these big black things here, those are the lungs. They're full of air. That's why they're black. And you can see lungs are supposed to be black, but these white dots here, that's not supposed to be there. That's kidney cancer, and that's what it looks like on CT scans. And so in this particular patient that I saw a few years ago, we had a really good response with Sunitinib because the tumors used to look like this. And then over here on this side, sorry, the pointer's going all over the place. On this side, you can't see those tumors anymore. And same down here, you can't see those tumors anymore. So that was a very good response. Sunitinib has side effects, though. So these drugs do not come without side effects. And they're listed here. So you could have high blood pressure, so we might have to manage that with blood pressure medications. I usually recommend that patients go to London Drugs or Shoppers Drug Mart and get their automatic blood pressure done just to make sure it's not too high. You can feel fatigued. Sometimes what works for fatigue is exercise, believe it or not, going out and doing things as opposed to staying at home. It can cause diarrhea. If you have a lot of diarrhea, we have to use a lot of Imodium or Lomotil, different drugs to stop the diarrhea. But if the diarrhea is really bad, there's also a special diet that you can use, something called the brat diet, which is composed of bran, rice, applesauce, and toast. And essentially they're just sticky things that bind up stool so that you don't have diarrhea as much. You can get hand-foot syndrome, so that sounds funny, but what it is just your hands and feet can be a bit sore and a bit red, and so we usually, for those of you on this drug, you've probably heard me say this, we usually ask you to moisturize as much as possible with Kerry lotion, or with Lubriderm, sometimes 5-10 times a day, and if there are any cracks in the skin, we get you to put polysporin in there. You can get mouth sores, and if you have mouth sores, there are good mouthwashes for that. I don't know, Bob, were they good mouthwashes?
Ice cream.
Ice cream worked well? Okay, ice cream works well too. Your hair can gray, your skin can yellow, you could get a skin rash. We have to check your thyroid, but that's easy to do. And there's also a risk of possible cardiac toxicity. Actually, we were Bob and I were talking about this. Bob was asking, have there been any results from that clinical trial that he participated in? And the main result that we're looking for isn't available yet. It'll probably be available in 2 to 3 years. But what we did find, though, is actually the rate of Sunitinib cardiac toxicity, meaning how often does Sutent maybe affect or weaken your heart, is actually not very much different from placebo. So that's a good thing. The cardiac toxicity rate is really low, in and around about 4%. So that's a result that came out of a clinical trial. And without patients going on clinical trials, we wouldn't have a result like that. So these are some pictures of hand-foot syndrome. So your hands and feet can be a bit sore here. And this is actually what it looks under the microscope. There's actually proliferation and hypertrophy of some of the skin under the skin. And interestingly, your hair can gray, and so this is some graying hair displayed to a normally brown-haired man. And it's interesting because Sutent is given 4 weeks on, 2 weeks off, 4 weeks on, 2 weeks off, so it's in a cycle like that. So if you pull out someone's hair, you could actually see nice brown hair for the 2 weeks, and then for 4 weeks it's white hair, and then back to brown hair again. So that's kind of neat. Everolimus is the next drug. Everolimus is a very common second-line drug. So after you progress on Sunitinib, we could use Everolimus. There's actually a clinical trial that looks at whether or not we should use Everolimus first. And so people are, some people in the room actually here are in that trial. And that was opened here in Calgary. This is the famous trial that led to Everolimus' approval. Basically, all drugs go under these very rigorous clinical trials where they take hundreds and hundreds of patients with kidney cancer, randomize them one group to something else and one group to the new drug. So for this one, it was Everolimus versus placebo, and it showed a big benefit in progression-free survival. So that's why we use it second line. There are some side effects with Everolimus. You could get fatigue, mouth ulcers, rash, diarrhea, and there's also an interesting side effect, pneumonitis, that's a bit unexpected. So your lungs can have a bit of inflammation in it. It's swelling and extra fluid in around your lungs, and that can make it difficult to breathe sometimes. So we have to watch out for that sometimes with chest x-rays. And so this drug is available to Albertans second line, actually all Canadians second line. There are other drugs as well, and some of them are newer. Axitinib, which is available by a special access program, this is becoming available now. So it was also studied in the second line setting, so we'll probably see a lot of this in the second line after initial Sunitinib. Pazopanib is another a drug that we could use in the first line, and we usually use this drug if patients couldn't tolerate the Sunitinib, or if we don't think that Sunitinib will work very well in them. Sometimes we use Pazopanib. There are also some older drugs, Temsirolimus, Sorafenib, Bevacizumab. They're not used as often here, but they are available, and some of you might actually be on them. But they're a bit older drugs. And when I say older, I mean about 4 or 5 years old, so it's not that old. It's just that the research and the pace of kidney cancer is so fast that 4 or 5 years is old now. So what about the future of metastatic kidney cancer? What are we working on? What are some of the clinical trials that we're looking at? And so there are a bunch of clinical trials. So let's start off with patients with localized disease. So those are actually Dr. Kawakami's patients, where patients don't have any metastases, that didn't spread anywhere, and it's just in the kidney, and then Dr. Kawakami takes it out. We'll talk about non-localized disease. We'll talk about some databases that you could actually help out in. So why is research important? Well, research is the only way we can improve patient outcomes for both current patients and future patients. So if you're on a clinical trial, there's actually a chance that the trial will benefit you, and you'll at least get closer follow-up. It'll help future patients, of course, because once we find out the results of that clinical trial, we'll be able to apply it to patients in the future. Without research, we wouldn't have had this treatment revolution. Those 7 new drugs that I talked to you about, they wouldn't have existed if we didn't have people enrolling in clinical trials. So adjuvant therapy, these are the patients that just have it in their kidney and it was taken out and there's nothing left over. What are the clinical trials available for that? These trials look at whether or not we can improve the cure rate. So it didn't spread, okay? It's just in the kidney, we took it out, and now we think the patient's cured. But how can we cure them even more? So increase the risk of cure. Well, there is a clinical trial, and it enrolls patients with higher risk kidney cancer. That's kidney cancer that's a little bit bigger, maybe above 2 to 7 centimeters, higher grade, or node positive disease. And those people who've had their nephrectomy, the nephrectomy had to be within 10 weeks, though, of seeing me, those patients are eligible to participate in the PROTECT clinical trial. So the PROTECT clinical trial randomizes half of the people to a drug called Pazopanib, which is one of the drugs that I talked about earlier. Pazopanib works really well in metastatic disease, so disease that's already spread. So what if we bring that drug up closer to when the disease hasn't spread yet? Can we reduce the risk of it coming back? So we're looking at that, giving patients Pazopanib for 1 year and placebo for 1 year. And here in Calgary, there's about 6 patients on this clinical trial. In the world, it's done about 2/3 of accrual, so I think there's about 600 patients in the world on this clinical trial so far, out of about 900. So we're still looking for patients here. So if you know a patient who's had a nephrectomy, taken out their kidney within about 10 weeks ago, let me know because they would be eligible for the PROTECT clinical trial. So what about clinical trials for non-localized disease where it's already spread? So now we're not trying to improve cure because unfortunately we can't. We don't have the power to cure patients with metastatic disease. But how do we improve disease control, improve shrinkage of the tumor? One of the hottest new things, remember I said immunotherapy with interferon, IL-2, we rarely use that now. But now there's next generation immunotherapy. So what next generation immunotherapy is, it's thought that your immune system has learned that your kidney cancer is okay. So your immune system doesn't do anything about it. It just lets it go its own business and grow. But that's not okay. So what PD-1 inhibitors do, this is a new drug class, what it does is it tries to retrain the immune system, rev up the immune system a little bit more to tell the immune system that, hey, that kidney cancer is not right. We should do something about it. We should attack it. And so that's what PD-1 inhibitors do. And so it's in clinical study now. Phase 1 trials have been done, phase 2 trials have been done, and response rates have been around 40% in terms of tumor shrinkage, despite getting previous Sunitinib, Everolimus, all these other drugs. So it does show some promise. It's definitely not ready to come out into clinical practice yet, but we have clinical trials ongoing looking at this. And so there will be a phase 3 clinical trial open here that looks at patients who've already had one VEGF inhibitor to see whether or not they should use this drug. There's currently a phase 1 trial that actually looks at combining a Sunitinib with this PD-1 inhibitor or Pazopanib with this PD-1 inhibitor. So those are very exciting studies that kidney cancer is undergoing. I would say if I had to choose, is there something that's really, really hot in kidney cancer in terms of the future, I think PD-1 inhibitors would be one of them. Here's something called TKI-258. This drug is so new, it just got its name Davitinib, okay? And so basically this clinical trial we had here, it randomizes patients to TKI-258 versus Sorafenib. They're both pills, targeted therapy. And basically we're trying to see whether or not this new drug, which is also another angiogenesis drug, would be suitable for people after they've already used Sutent, after they've already used Everolimus. And so that trial has already completed accrual, meaning it doesn't need any more patients, but we're still waiting for the results, and hopefully they'll come in about a year or so. Here's a really cool study, Sunitinib individualized dosing. It's something that's homegrown, it's Canadian, it's out of Toronto, and a bunch of investigators got together to ask a simple question, are we giving the right dose of these drugs? Because Sunitinib is dosed 50 milligrams, 4 weeks on, 2 weeks off. Everyone gets this. If you're 500 pounds, you get that. If you're 100 pounds, you get that. Same dose. So that can't be right. So what this study does is it doses patients based on side effects. So if you do have side effects, then that's great. That's probably the right dose for you, and you'll probably get some sort of benefit from this drug. But if you don't have side effects, if you're just, it's as if nothing's happening and you're not getting any drug, then this trial looks at escalating the dose to increase the dose to see whether or not we could get more efficacy. So that trial is actually opening up here in Calgary very, very soon, within the next month. It's already open up in Edmonton. For those of you up in Edmonton, this trial is already open. It's only open for people who haven't started Sunitinib before, though. So if you have already started Sunitinib, unfortunately, you wouldn't be able to participate in this trial. Oh, those are some clinical trials that are open here. There are other ones too, and other ones that are in development that are pretty exciting. But what about some research behind the scenes? Because clinical trials are really cool, they're very expensive. But what about some other research that's not as expensive, that's a little bit more behind the scenes? We like asking questions like, if we use these drugs, are we actually improving patient outcomes? What sort of factors predict how patient A will do versus how patient B will do? And are there any characteristics that will select how patients that will do well with drug A versus drug B? And those sort of projects relate to patient-tailored care because, all of these drugs, we apply them to everyone, but is there some sort of specific thing that we should be following next time? Maybe in 5 years or so, I might tell you, well, if you're a group A patient, then you must use this drug. If you're a group B patient, you must use this drug. But we don't have that sort of classification yet because we don't know enough about kidney cancer. So as Joan had alluded to, I'm the chair of the International mRCC Database Consortium. And what this is it's an 18-member organization from the US, from Japan, Korea, Canada, Denmark. And basically what we do is we pool all of our collective knowledge together. We put all of our kidney cancer patients into this database so we can learn from each other's experiences. And that's really, really helpful because, as you know, kidney cancer isn't that common. So it's really helpful to pool together everyone's knowledge to see if we can learn from that. So in this database, we currently have about 2,400 patients treated with targeted therapy with metastatic disease. So we've learned a lot from this consortium, actually. We learned that Sunitinib is better than interferon immunotherapy in a population-based analysis, and it was actually that paper that helped get funding for Sunitinib in Canada. We learned that there are 6 prognostic factors that can predict how well a patient does with targeted therapy. They can sort of predict how well people do with targeted therapy. We also learned that perhaps taking out the kidney in the setting of metastatic disease, so even if the kidney cancer already spread somewhere else, in select patients, maybe taking out the kidney is a good idea, as Dr. Kawakami alluded to. And we identified that, you had to be a good performance status to benefit from that. And finally, we also learned more recently that the longer you are on targeted therapy, so the longer you're able to tolerate targeted therapy and be on it, this is for metastatic disease, not disease that's already been taken out, but the longer you're able to be on targeted therapy, the longer you have left to live, actually. So that was an interesting statistical analysis. So that was the International Database Consortium. Are we doing anything in Canada? Yes, we are. There's something called the Canadian Kidney Cancer Information System, CKCIS. It's actually homegrown here in Canada. And what it tries to do is it tries to track Canadian patients, look at Canadian outcomes, see how they're doing, make sure that we're doing just as well as other countries, and also try to look out for these things, these treatment patterns where maybe Group A is doing better than Group B. Well, what made them do better? What is it about them that made them do better? Can we learn from that a little bit more? So this Canadian Kidney Cancer Information System is a database that a lot of Canadian centres participated, including ourselves here in Calgary, and it's Canada-wide. And it asks important questions such as which drugs help the most? If you are a patient with these sort of characteristics, what drugs might help you better, for example? Does doing surgery help? What type of surgery? Or is there a specific thing about that surgery that helps a patient a little bit more? And what can predict successful treatment? So this sort of database analysis allows us to do that. So there's actually a consent form, and many of you, most of you, have probably already been approached to be a part of this database. If you haven't been approached to be a part of this database, I have consent forms here that you can take and sign. And what all it does is it allows us to look into your information and be able to contribute it to the Canadian Kidney Cancer Information System. No one will ever contact you. No one will ever publish your name. All results will always be reported in composite format, so it's completely confidential. And so if you're interested in signing up for that and contributing your information, please, I have consent forms right under Bob, actually, if you're interested in signing. So what do I expect in the future? What do we have currently in the present? So right now, everyone gets the same drug. Okay, so everyone, because we don't know any better. So the types of drugs that we have are applied uniformly for patients with metastatic disease. But one day in the future, I'd like to see that a certain patient gets a certain drug that's suited for them, that will work best in them. And so one day our research will be able to find that for us. In the present, everyone gets 1 or 2 drugs, but in the future, I'd like to see everyone get access to all drugs. There are 7 drugs available in kidney cancer, so one day I'd like to see all 7 of those drugs be available to everyone, and maybe if there are 14 drugs, then all 14 drugs available to everyone. Currently, in this new targeted therapy era for patients with metastatic disease, patients now live twice as long compared to their counterparts 5 years ago. So with targeted therapy, people live twice as long. And so what I'd like to see in the future is that people live 10 times as long, or actually even better, one step more than that, patients are actually cured of their cancer. So we can't do this without your help. Please enroll into a clinical trial if it's available. Please help us support our research efforts. Ask if there's a clinical trial you can help open here in Calgary or Edmonton if you wanted to donate money, and there was a patient that donated $10,000, and because of that we were able to open up a clinical trial here that we wouldn't have been able to open up before. Support the KCC. They're an excellent organization, great for patient information, and the Alberta Cancer Foundation. So we've come very far with all of these new drugs, but we have a lot more to do. We're not that great yet. Now we're looking at a whole bunch of clinical trials. I didn't talk about this, but there are different combinations of drugs that we're using, different sequences of drugs that we're using, and drugs that are newer, better, might work a little bit better. Angiogenesis, the new blood vessel formation, is very important in kidney cancer, and that's what we're targeting with VEGF and mTOR pathways. And finally, medical advances can't be possible without the participants of thousands of people worldwide in clinical trials. So with that, I'll end, and we'll take questions at the end. Thank you very much.